presenter of the day is Ted Campbell. Ted Campbell is a registered dietitian and clinical instructor at the University of Texas Southwestern Medical Center at Dallas. He has worked in several multidisciplinary clinics on the UT Southwestern campus and in the Dallas community, focusing on neuromuscular conditions like multiple sclerosis and ALS, as well as HIV/AIDS. In addition to his clinical duties, he also teaches food science and technology, nutrition in growth and development, business of healthcare, nutrition in chronic care, the Master of Clinical Nutrition Coordinated Program. He holds a Bachelor of Business Administration degree from Baylor University, as well as a Master of Clinical Nutrition from UT Southwestern. Thank you for joining us today, Tad, and you may take the floor. I'll have you share.
All right, thank you. Well, I'm Tad Campbell, and I'm a registered dietitian. As Michelle said, I'm a clinical instructor at UT Southwestern Medical Center, and I've worked with several neurological conditions over my career with a strong emphasis in multiple sclerosis and ALS. I've been on the multidisciplinary team at the ALS clinic at Texas Neurology, which is a private practice here in Dallas, for about 10 years. One more thing about me, I love to travel and just got back this weekend from Costa Rica. So if you have not been, I hope you can. If you have, then I hope you love it as much as I do. So as we go through this afternoon's talk, I hope to at least answer these broad questions. Hopefully cover more than this, but at least these. Number one, why is good nutrition important in ALS? Does an individual with ALS need to make any food modifications? Does an individual with ALS need to stay away from any foods? And what food choices can an individual with ALS make to improve their quality of life? Okay, this slide looks busy, but just bear with me. I'm quite biased. I would like to believe that nutrition is sort of the beginning and end of things, but it really does take a team of providers to make a successful multidisciplinary clinic. Our clinic is made up of all of these specialties that you see on the screen, as well as our MD, registered nurse, and medical assistant kind of you see down the middle. So we have a speech language pathologist, a respiratory therapist, occupational therapist, a durable medical equipment representative, a physical therapist, and myself, the registered dietitian nutritionist. And like I said, I'm sorry for the busy graphic, and I started trying to change it to make it less busy, but then I realized it's actually a pretty good representation of the sort of controlled chaos that goes on in our clinic twice a month. Our clinic is an open setting, so we each see every patient. In our efforts to do so, to get all the patients moved through as quickly as we can, it can get pretty hectic, but we like it. Our patients tend to like it. And as you'll see, there is significant overlap among each of us and our disciplines. And I hope to show you not only the importance of nutrition in ALS, but also where nutrition intersects with each discipline as we go through this afternoon. When it comes down to it, we have a few nutrition goals in ALS, and my recommendations are geared toward helping the patient meet these goals regardless of the progress or state of their disease. Not only are ALS patients at high risk for malnutrition, but the literature shows improved outcomes when weight is maintained. This helps to optimize energy for other tasks like maintaining mobility, improved respiration, and speaking. Liquids can present special difficulties in ALS, so remaining hydrated is another nutritional goal. And overriding all of these goals is safety. We monitor our patients' ability to chew and safely swallow, and then work with them to reduce their risk of aspiration. So to begin with, in clinic, we'll start with a nutritional assessment for each patient, where we're looking for changes in the patient's nutritional status. Are they losing weight? Are they becoming malnourished? We'll ask questions about how much they're able to eat at a time or in a day. If they have a feeding tube, we'll ask how much of their formula they're able to take each day and evaluate their tolerance of it. If the patient's weight has changed, then we'll ask probing questions to try and determine why. Things like, have your symptoms changed in such a way that your intake is more affected than before? Have you developed new chewing or swallowing issues, maybe that weren't present at your last clinic? If the patient has a feeding tube, are they able to take all the necessary formula as expected? And if not, we try to determine if that's because of the concentration of the formula or the volume that's needed to meet their energy and protein requirements. If we're discussing or talking to an existing patient, then I'm going to follow up on any issue or suggestions from their prior visit. Were they able to try the recommendations I made? If not, why? And can I find a new way to meet that need that's more doable for them? So we'll find out if there are new concerns like chewing, swallowing, fatigue, loss of function, or taste and appetite changes that have arisen since the last clinic. And finally, I'll make new recommendations for the patient to try between this and their next clinic. So goal number 1, maintaining your weight. Before we get into that, before we get started about maintaining weight, I have to say that while we accept that the overriding rule with ALS and nutrition is to not lose weight, it may be permissible if the patient's breathing is affected by the weight, and in these cases, some weight loss is acceptable. There are not well-established guidelines for this. So the dietitian will work with the respiratory therapist, as you can see in this little Venn diagram, using clinical judgment and monitor the patient's weight and breathing function. So weight maintenance primarily comes down to energy balance or energy surplus should they need to gain weight. It sounds simple, but ALS is particularly cruel in that about 50% of patients are hypermetabolic, which increases the number of calories they need by 10 to 15%, while simultaneously making it increasingly difficult to physically consume adequate calories. These difficulties appear as various problems in feeding and in an inability to consume an adequate volume of food to meet energy needs. We have various strategies to achieve energy balance or surplus where needed in oral nutrition, and when necessary, we will employ the use of a feeding tube. There are many feeding concerns to be aware of and to assess each patient for. As I discuss these, you'll see how these disciplines represented in these circles here overlap. First of all, hand and arm strength or dexterity. When a patient does not have good command of their arms and their hands, the decline in limb strength and usage will result in weight loss, likely before total function is lost. This is one of the problems that I like to warn every patient about, to pay attention so weight loss doesn't sneak up on them in case they hadn't thought of this as a feeding issue. I also frequently ask spouses and caretakers to pay attention to this as it can be subtle. Fatigue. Fatigue is a major concern. Getting tired while eating, whether it's because of the mouth, neck, arms, hands, or core, that will cause both weight loss and potentially a safety concern as swallowing becomes more difficult and more dangerous when we're tired. Another risk attributable to fatigue is simply how long it takes to get a meal down. When it's taking 2 hours, 3 hours to eat a plate of food, it's very common for a patient to eat just enough to no longer be hungry, but not enough to really meet their needs. And while that's an excellent weight loss strategy in almost any other population, you can see that it is a real problem in the ALS community. Choking can happen for a lot of reasons, ranging from loss of muscle function and control to fatigue to choosing foods that are just not good choices with dysphagia. And I'll discuss some of these in a second. Independence is important, but when self-feeding becomes too difficult or impossible, we may recommend someone feed the patient. I always discuss the challenges of this with patients and their caretakers. This very often leads to unnecessary frustration and inadequate consumption. We discuss the importance of communication and that it's not personal if the patient asks their feeder to speed up or slow down or to provide larger or smaller bites. Lack of this communication can lead to choking, aspiration, or just marital upset, and we don't really want any of those. In fact, I teach a neurology lab every spring to dietetic students where one of the exercises is them sitting down and feeding each other. So that way they'll have an understanding of what it is like for both the patient and the one feeding them. Some patients experience changes in taste or a decreased appetite. These are particularly difficult to overcome as it's really hard to eat when food doesn't taste right or when you simply aren't hungry. I mentioned fear. Fear can also be a real challenge. A patient who's frequently choking, especially one who has aspirated in the past and had the consequences of aspiration pneumonia, may develop an actual fear of eating, which leads to avoidance. And avoiding eating and drinking then creates new problems. This is often done so the patient can prevent or limit his or her trips to the bathroom. We have to work around this with methods that may include timing of intake and bowel training. So as you can see, addressing these concerns may require the assistance of the occupational therapist, the physical therapist, and the speech-language pathologist. For many of the reasons that I just discussed, a patient may not be able to consume enough food to get adequate calories to maintain their weight. This is why we recommend all the nutrient and calorically dense foods that you're all probably used to hearing about: gravies, sauces, creams, etc. When a patient goes down to only eating, say, 75% of a meal, then we try to get the calories of 100% of the meal into about 75% or less of the volume. And we have some strategies for that. Some people find it easier to get more calories and protein in by creating very nutrient and calorie dense shakes and smoothies. This is often just a collection of things that they like thrown in a blender. Some will add full fat dairy, greens that may otherwise choke them, liquid supplements, powdered milk, protein powders, or even healthy fats like avocados and nut butters. So calories, calories, calories. How do we get more calories in with less volume to consume? We promote a high calorie, high protein eating pattern. This may be as simple as maybe adding fat sources to foods you're already eating, like butter, avocado, sour cream, gravies, sauces. For patients with difficulty chewing or swallowing, we may recommend soft, damp, and easy to eat foods like mac and cheese, potatoes and gravy, cheese enchiladas, ice cream, tuna salad, boiled or scrambled eggs. And we may also need to add something to their foods like binocalorie, binoprotein, or prostat. These are additives that offer high calories and or protein in small volumes and in powder or liquid form that make it easy to administer. I would just note here that binocalorie should not be added to a feeding tube. But you can see I've listed here for you sort of the statistic or the stats on each of them. The size, they're all 1.5 ounces or less. Prostat, 100 calories, 15 grams of protein, and that comes in liquid or powder. Binoprotein is 1/4 ounce, 25 calories, 6 grams of produce, it comes as a powder. And then binocalorie is only 1.5 ounces, but provides 330 calories and 7 grams of protein, and it comes in liquid form. But sometimes we just can't eat enough. And in those times, then we recommend various supplements. Common ones are Boost and Ensure, but keep in mind there are also much higher calorie options like Boost Plus, which is 360 calories. Boost Very High Calorie, or you may see it called VHC, is 500 or 540, something like that. Whichever one you choose, be sure you look at the calories. Many of the drinks that are marketed as high protein, that are high protein, but they're not all that high in calories. Kate Farms makes, this is it on the bottom left, makes an oral nutrition supplement that's organic, has no artificial sweeteners, no dairy, no gluten. For those who have dietary restrictions, that's a very good option. A lot of people find that brand quite tasty as well, but I will warn you, it's quite expensive. So I will frequently send samples from the manufacturer to the patient's home to make sure they like it before they spend their own money on it. Carnation Breakfast Essentials is an oldie but a goodie. It used to be called Carnation Instant Breakfast. It's inexpensive, easily accessible. It's at every grocery store, nutritious, and it can be added to whole milk or used with ice cream in a shake. You could also add any of the additives discussed on the prior slide to amp up the calories. Some patients will even add just heavy cream to it to increase calories. And ice cream. Ice cream is a common recommendation in our clinic, but you have to keep in mind that when ice cream melts, as it does in your mouth, then it becomes a thin liquid. So if swallowing thin liquids is problematic, then regular ice cream is probably not a great solution. Okay, feeding tubes. There are a couple of reasons why we would recommend a feeding tube to our ALS patients. And there are a couple of types of tubes. First, a PEG. A PEG is a percutaneous endoscopic gastrostomy. This tube is surgically inserted through the abdomen, and it allows for foods, fluids, and medications to be given directly into the stomach. When we've exhausted the strategies we already discussed and the patient is still unable to consume adequate energy for whatever reason, be it dysphagia, lack of appetite, or changes in taste, then we will probably make this recommendation. The AAN recommends forced vital capacity, which is a respiratory measurement, be above 50% of predicted value to undergo the procedure of PEG placement. So if the forced vital capacity has a big drop between clinics or when it's approaching 50%, we may make the recommendation to go ahead and get the feeding tube, whether or not you're losing weight. A rig is very similar to a PEG, with the primary difference really being the method of insertion. The rig stands for radiologically inserted gastrostomy. This is the route you would need to go if FVC goes below 50%. It's inserted under fluoroscopic guidance by the radiology department and does not require full sedation. As one might guess, the recommendation of getting a feeding tube just is not always embraced right away. Unlike some diseases that folks may be more familiar with, ALS doesn't follow a linear pattern. So we can't say, first you're going to lose function in your arms and then you'll experience this difficulty, et cetera, et cetera. No, it happens when and where it happens. Some impairments may not ever happen, but we want our patients to be prepared for all possibilities. So you can imagine that we commonly encounter challenges with patients accepting this recommendation. People all come to our clinic with their own unique experiences and ideas. So we have to work to make sure they have the most accurate information that we can provide and work to respectfully dispel inaccurate information as well as address any fears that they're able to communicate. A really common fear is that people are afraid that they'll never be able to eat again once they have this feeding tube. So we're sure to point out that, yeah, you can still eat, you can eat for pleasure, and you can have as much of whatever you want, provided that you can safely chew and swallow it. And you can see by my overlapping circles that while the dietitian will address it with the patient, the need for a feeding tube may be discovered by the RD, the respiratory therapist, or the speech pathologist. This image does a pretty good job of just showing how a feeding tube is placed and how it functions. In the case of a PEG, it's surgically placed into the stomach While the patient is under general anesthesia, the doctor inserts a tube with a camera and a light on it. They go down the esophagus and into the stomach. When they reach the stomach, they turn the light up to the outside and you can see it through the skin. Where they see the light, they cut, the tube is inserted, a retention balloon, as you can see here on the inside wall of the stomach, is inflated, filled with saline, and that's it. The patient's now able to skip their mouth and esophagus and push nutrition directly into the stomach. Many people see a feeding tube as frightening and as a much bigger deal than it really is. I like to remind our patients that we use glasses because our eyes don't work correctly. We use a walker or a wheelchair because our legs don't work right. And we can just as easily use a feeding tube if our mouth and throat aren't working right. Most patients with a feeding tube will just need to do gravity feeds. And that means they connect a syringe or a bag to the tube, pour the formula into that bag or syringe, and then just let the formula drip in at the rate that gravity would bring it in. Taking in an adequate volume of formula is still a concern. So we'll typically start with a more concentrated, meaning more calories and less volume, but easily tolerated formula. When the volume is still difficult to accommodate, we may need to move to a pump. Feeding pumps are very rare, but it's still an option should we need it. For instance, in the case of a patient who's had maybe a bariatric surgery in the past and therefore has a physical limitation on how much their stomach can hold at a time, it may be necessary to pump the formula at a slower rate than maybe what gravity would for them. Listed under typical formulas here, you can see some common formulas that we may start someone on. And you'll see there's a number that follows the names of these, like isosource 1.5 or 2-cal, HN 2.0. That number indicates how many calories are in each milliliter of that formula. The higher the number, the more concentrated it is, and therefore the less of it by volume you'll need to consume to meet your energy and protein needs. In addition to these standard sort of Nestle and Abbott formulas that people tend to be more familiar with, there are several other options that I find are especially popular within the ALS community because they're made from real foods or formulated as hypoallergenic. Many patients will ask for them by name, but if I know that you have specific dietary restrictions, I would likely recommend one of these right away. And the ones that are most common, at least in our clinic, are Liquid Hope, Real Food Blends, and Cape Farm. All right, second goal is maintaining proper hydration. I work very closely with our speech-language pathologist in the area of hydration, as swallowing function is so often impaired. As you likely know, hydration is important in preventing constipation. It can be helpful with dry mouth. A lot of our patients, especially those on multiple medications, complain of dry mouth. Oops. Sorry. Maintaining hydration, though, is a problem for most, even in just the general population, but it's particularly difficult to remain hydrated when you're unable to safely swallow liquids. We don't generally distinguish which fluids are best. We just need you to get fluids. Obviously, I think water is the best option, but I'm good with whatever the patient will drink. I once had a patient drinking 12 Dr. Peppers a day, and he decided to stop drinking those because he wanted to be what he thought would be healthy. And then he lost 14 pounds. So that's not the outcome we were looking for. Your dietitian can help you come up with, if you want to replace sodas, we can come up with some better options for you. While we promote fluids, they have to be safe. This is where we work with the speech pathologist to determine whether or not The patient may need a thickened liquid. Maybe they need swallow strategies like chin tucking or turning their head when they swallow, or even a feeding tube if necessary. Another sort of less discussed issue with hydration is that the difficulty some patients have with getting to the toilet will often cause them to restrict their fluids. This can be an issue with food as well, but it's much more common when it comes to fluids. And at almost every clinic, I have someone report that they're limiting their water intake so they don't have to go to the toilet. Maybe it's difficult walking to the bathroom, or maybe transferring from the wheelchair to the commode is not an option for them to do by themselves. And in these cases, I work with the patient to time their fluid intake in such a way that it minimizes the number of trips that they have to make, or for a time when they have someone there to assist. So maybe they try to drink a glass of water when they first wake up, maybe another glass with their medication, another with each meal, and maybe another when their caretaker arrives. We commonly recommend portable urinals and condom catheters as well, just whatever it takes to remove that barrier. Loss of function is another big barrier. It could be weakened arms or even the inability to lean your head back to take a drink. For those who can't lift a drink, we might recommend a Camelback or a cup holder on their wheelchair with a really long straw. For those who can't tip the cup because they can't lean their head back, we may recommend a nosy cup. And this is a cup with a notch cut out of it that allows you to just tilt the glass without your nose getting in the way. And I have a picture of one coming up. And then finally, again, fear of choking can be another common reason people with ALS don't drink enough. Maintaining safety. As I said, safety first. While calories are a priority, they must be consumed safely, and that is without choking or aspiration. This is a particular concern with bulbar onset, as there are many potential problems in the mouth. For these patients, we'll make recommendations to help reduce the risk and allow them options to safely eat and drink that may include modifying the texture of foods or the thickness of liquids. This can require the input of the speech-language pathologist as well. And fatigue while eating or drinking is also dangerous, so we may offer suggestions to avoid this. All right, we may need to modify the texture of foods or the thickness of liquids just to make them safe and easier to consume. We may recommend foods that are easy to chew and swallow in their natural state, or some that have been modified by mechanical means. Soft foods may be foods like mac and cheese, oatmeal, mashed or baked potatoes, tuna salad. These are all foods that don't require a lot of manipulation in the mouth. They're damp or can easily be dampened with toppings like butter and sour cream, and they're naturally soft. When chewing is a little more difficult, we may move to foods that are ground or minced and moist. This may also be referred to as a mechanical diet, as the foods have been mechanically modified by grinding or mincing them. And ground beef or turkey are pretty easy foods to imagine that fall into that diet. They've been mechanically altered by grinding them or by mincing them. This lets the patient have to chew less, and it provides a larger surface area for sauces to help lubricate the food for swallowing. And for those who have difficulty with both chewing and swallowing, they may need to move to pureed foods. I have attended and taught entire classes on pureeing, but the primary thing is you need a very good blender. Okay, not being able to control the tongue will cause liquids to proceed too quickly down the throat. For those with dysphagia, we may recommend thickened liquids to slow the process down and mitigate the risk of choking. As you guess, thickened liquids are not everyone's favorite and are frequently declined. We may provide samples of various thickeners like Thicket or Simply Thick, or pre-thickened samples so the patient can try it and see if they'll stick with it before buying them on their own and spending their own money. If you look at here in the middle, kind of the bottom middle, it says butter pecan. This is a magic cup, and I am very fond of magic cups. These are a safe option for those who need the calories of ice cream, but can't tolerate thin liquids. I've included them here because they're ice creams that are the consistency of pudding when they melt. They're high calorie, fairly high protein, being that they have 290 calories and 9 grams of protein in just 4 ounces. And they're also very tasty. The speech therapist and I work closely on these safety concerns. Here you see a list of some common, soft, easy to chew and swallow foods. As you look over the list, think of ways you can add calories to these items. In fact, that's one of the recommendations I provide to most of my ALS patients in clinic is whatever you're eating, think what would make this more caloric? What could I put on top of this? Ranch dressing, I don't know, cheese, cream cheese, whatever you like. And here's a list of some common pureed texture foods. First off, blenderized foods. You can blenderize just about anything into a puree if you've got a really good blender. That Oster that you bought in college to make margaritas, that's not gonna work. You need at least a NutriBullet or a Ninja, but the best option is definitely a Vitamix. Just be sure there's adequate liquid to keep it spinning. And you have to go until it's completely smooth with no lumps. Most people automatically have a negative response to pureed foods, but I just challenge you to try it. In my dysphagia class, we've pureed Raising Cane's chicken strips. This year we did a McDonald's big breakfast. We've done pizza in the past, and they're all pretty great. I think they're tasty. But listed here are some other common foods that are pureed texture. Applesauce, thick creamy soups, refried beans, puddings, yogurt, and even baby food. When the muscles of the tongue or throat have been affected by ALS, then controlling the food and drink in the mouth becomes difficult, if not impossible. And then the patient is then subject to the laws of gravity and fluid dynamics. Like, it will result in aspiration as the liquids will simply flow downward and they may enter the breathing space. This can be particularly problematic with foods of mixed textures. And when I say mixed textures, think foods that are made up of both liquids and solids. Things like cereal with milk, or stews with chunks of meat in it, or vegetables in broth, chicken noodle soup. All of those are foods that are both liquid and solid. A healthy person's tongue will just safely hold the liquid in the middle of their mouth while their teeth chew up the solids. Then the tongue combines them all to swallow. In a bulbar onset ALS patient who's lost function in their tongue, they're not able to perform that complicated yet often not even considered action, resulting in a choking hazard when the tongue is unable to control that liquid. For these patients, we will recommend soups of one consistent texture, like a blended broccoli and cheese, or creamy potato, or tomato basil. Those creamy options have the additional benefit of being high in calories as well. So some patients even will let their cereal absorb the milk until it's soggy and almost like one thick consistency, or maybe just switch to grits or oatmeal. There's also several well-known choking hazards that we should probably, in my opinion, just avoid. Crummy foods like crusty breads and crackers. They tend to create a cloud of crumbs in your mouth when you bite into them. These crumbs can stick in the throat, cause you to choke. The same is true of plain, just like dry plain rice, shredded coconut, some greens like raw spinach or lettuce. And those are all of those items are pretty low in calories, and the other nutrients that they offer can much more safely be gotten from other foods. So I find it best to err on the side of safety and just avoid those. Remember I mentioned fatigue earlier being a safety issue? Well, for this, we try to help the patient conserve their energy. Choose foods that require the least amount of oral manipulation. Don't allow distractions like television or radio during meal times, and no talking while eating. It may not be the typical American eating pattern, but we may recommend that you have your largest meal earlier in the day when you've got more energy, or have a nap or take a rest before starting a meal. It can often be easier to load a drink or shake up with calories, so if swallowing is safe, we may recommend a high-calorie supplement or a shake. Sometimes people need feeding assistance. Can't feed yourself, someone may need to help you. Feeding someone seems like a no-brainer, but for patients who need assistance in feeding, it's important for the one doing the feeding to go slowly and for both of you to communicate clearly. The patient has to let the person feeding them know if they need to slow down, speed up, or give different size bites. Rushing this process will result in frustration as well as likely aspiration. So communication is key. For those who can't feed themselves, but with difficulty, it may be necessary to employ adaptive utensils, dishes, or other adaptive equipment. Here in the middle, you can see I've got a picture here of bendable, easy grip utensils. This one you can't see it, there's a finger loop utensil. This is an ADL cuff that you can put things into and use with your hand. Provali cups, these only allow a certain amount of liquid to go through with each drink. So 5 milliliters, 10 milliliters. And this is that nosy cutout cup that I was talking about earlier. To drink out of it, you drink out of the solid side and just tip up the other side and let your nose kind of go into that indention, and it clears it without your nose getting in the way. So these have been modified and adapted so the more complicated and intricate movements typically required from fingers and hands aren't necessary. You'll see this lady on the bottom left, this is a headmaster brace, and patients who are unable to hold their head up to eat may benefit from a headmaster. And for the really cutting edge folks, there's even robots that can help in feeding. This white one in the middle, his name is Obi, and this black one is Mealtime Partners. Those are two pretty well-known options. They can be very expensive, and they certainly don't alleviate all of the feeding issues one may experience, but they can help to provide a level of independence. There's also, in the top right, you see a lady with a more mechanical option. These are stable support systems, and this one, while it's less techy, so maybe less exciting, it's also way much more affordable. So, in summary, it takes a team to accomplish nutrition goals in ALS. Maintaining weight and hydration status are primary nutrition goals with ALS. Problems like limb weakness or fatigue may not appear at first to be nutrition problems, but over time, they will result in weight loss. When ALS is making it hard to eat enough calories, we have strategies to help with that. Remember, choose higher calorie foods, add high calorie items to foods, and supplement with high calorie drinks. Safety is paramount. We don't want anyone aspirating, so choose the best and safest texture for foods and the best and safest thickness for liquids. Utilize adaptive utensils and equipment when necessary, and if you need it, have feeding assistance. And finally, for those who need them, feeding tubes are a good option. But wait, back to those questions that I posed at the beginning. Did I answer them? Let's see. Why is good nutrition important in ALS? Being well nourished helps provide energy for other important tasks like ambulation, speaking, and breathing. And good nutrition is important in ALS because maintaining weight provides better overall outcomes and quality of life. Does an individual with ALS need to make any food modifications? Well, people with ALS may need to modify not only the food they eat, but also the way they eat it. Start with choosing higher calorie foods When necessary, add high-calorie items to your foods. Supplemental nutrition and calories may be required, like Boost Ensure, I mentioned Boost VHC, milkshakes. If necessary, people with ALS should choose the easiest food for them to safely chew and swallow. That could mean choosing foods that are soft and moist naturally, like fish or cheesy scrambled eggs or mac and cheese. It may mean that they need to mechanically alter foods through grinding, mashing, or mincing, like meatloaf or mashed potatoes. And when necessary, choose smoothly pureed foods that do not require chewing and are thick enough to safely swallow. And finally, when a patient is unable to feed him or herself, get assistance with feeding. This could be from a spouse, caretaker, friend, or apparently even a robot. Does an individual with ALS need to stay away from any foods? Well, dietitians like to say there are no bad foods, and there aren't. However, in ALS, there are certainly some foods that are not as safe as others. These include small and dry foods like rice, shredded coconut, the crumbs produced by crunchy foods like crackers and crusty breads, foods with both liquid and solids, and in some cases, even just thin liquids. All right, what food choices can an individual with ALS make to improve their quality of life? Ways for someone with ALS to improve their quality of life through food choices include choosing those high-calorie foods that will provide the most calories in the smallest volume. For foods that are not high-calorie to begin with, add calorie sources to them with things like butter, sauces, gravies, mayonnaise, dressings, and the like. This will both moisten the food, making it easier to swallow, as well as add calories. To reduce the nutritional effects of fatigue, eat your larger meals earlier in the day before you get too tired, and reduce distractions during mealtime. Turn off the TV, don't try to speak when you eat, and when needed, get a feeding tube. This is just a list of websites that I think you might find useful. Some of these products I discussed in the presentation. For those of you who would like to nerd out on scientific literature, these are a couple of really good ones. And with that, I'd love to answer any questions that you have.
Thank you, Tad. We already have some questions that have come in, but if you have any questions on nutrition, please hover over the bottom of your screen. You'll see a Q&A bubble. Type in your question and submit, and we will try and get to as many as we can in the next 10 minutes. Here's one. Tad, any tips to mitigate swallowing difficulties apart from thickeners?
Yeah, it depends on what the cause of the difficulty is. In some cases, it may be beneficial to tuck your chin. I don't know if you can see me, it's not very flattering, but tuck your chin as far down as you can when you swallow. That will physically close off the airspace. Also, this is really more of the purview of the speech language pathologist, but in some cases, I know that they will recommend that the patient turn their head whenever they swallow. And then choosing those drinks that are naturally thicker, like dairy products and such.
Thank you. Another question that has come in. What can I do with a patient who is constantly choking? The issue is the patient gets choking when is eating, sleeping, or awake. Sometimes gets blue from lack of oxygen. Patient feels a gas that doesn't let them breathe right, and the patient has the fluid blenderized.
So, I mean, without knowing the patient, I think the best suggestion there would be to get to a multidisciplinary clinic, because I heard at least 4 disciplines that need to address that patient.
Yes, and if you're looking for an MDA clinic with a nutritionist, if you email our resource center at resourcecenter@mdausa.org, they will find you a nutritionist that is close to your area.
But I mean, I don't want to leave them without, without some sort of answer there.
Yeah.
But without knowing the patient, they need to be assessed for a feeding tube. It may be time that that throat is just through doing its job, and it may be time to get that patient a feeding tube so we can skip that section of the GI tract, go straight into the stomach, and be sure that they're safely receiving all of the calories, nutrition, and liquids that they need.
And the Resource Center email has been added to the chat. So if anybody would like to email the Resource Center for a nutritionist near you, please reach out to the Resource Center. Another question that has come in is, besides FVC, is there a reason to prefer PEG versus RIG? Lots of acronyms here.
Yeah, getting a rig, you're going to be wide awake. And so the fact that the PEG is inserted under general anesthesia it's reason enough for me. That to me is probably the best option.
Is it possible to eat normally while having a feeding tube? So maybe only for particular administrations while keep eating at the same time?
Absolutely. Yeah, and that's one of the things that I definitely always want to make clear to people. You don't have to use that tube just because you have it. For instance, you know, in the case of the patient that I mentioned earlier where the FVC had dropped, you know, that patient, your respiratory function may be affected more than your GI or hands. And so in that case, yeah, you may need to go get the feeding tube inserted, but you can chew and swallow perfectly fine. We would just recommend you do it before FVC drops too low. But yeah, as long as you are able to safely eat and drink, you can have whatever you want orally. Some people even use it just for hydration. They don't think to drink, and that has nothing to do with ALS. That's just decided the human condition. A lot of people don't think enough to drink or don't think to drink enough. And so I know a lot of people who will just push water into their tube.
Another question that has come in, are the total calories or the macros more important?
So it's really total calories. We have to prioritize. And when I prioritize sort of all of nutrition, what I look at with ALS is that it's difficult. It becomes difficult to get food into your face. So whatever foods you can get, I'm not going to split hairs over whether you have more carbohydrate or more fat. The literature, one of the articles that I included in that presentation at the end was a systematic review over, I think it was 5 studies, and that were studying macros. And they were fairly inconclusive. I've seen studies that say, you know, low carb diet is absolutely the best. I've seen one that says high carb is the best. What all of the studies have in common is they're very small. They're not very powerful. And so when that's the case, then we go with what we know for sure, or as close to sure as possible, and that is total calories. We want to achieve at least energy balance, where you're taking in as many calories as you're putting out. And if you need to gain weight, then we want to have an energy surplus. So total calories.
If you didn't get a chance to write down the resources that Tad had on his presentation, we will be listing them out in an email that will go out to everyone. So no need to write frantically if you didn't have a chance to. I don't see any more questions. We will give it a few just in case any come in. Tad, is there a way to, is there financial resources and support to buy those pricey, smart robotic meal helpers?
So my patients have not been super successful with it, no. The VA, if you're a veteran, I know that the VA has provided them before. I know that, I believe OB has maybe a leasing option. There may be, you know, I don't know, MDA, do you guys have like an equipment closet?
If we have any resources, reach out to our resource center because they are the gurus of all of the financial support organizations that could help individuals out. I was just asking if you knew any off the top of your head.
No.
Well, it looks like no other questions have come in. So I will share my screen one more time. Tad, thank you so much today for presenting on ALS and nutrition. We really appreciate it. Thank you so much.
Thank you.